many negative outcomes. So what should we watch out for when we're placing immediate implant? This is a systematic review by the group in Ghent University in Belgium, which showed that the most important aspect of immediate implant placement that can prevent the recession has to do with the position of the implant. If you place an implant to the facial aspect, you're 17 times more likely to cause recession on that implant. So the most important thing you watch out for is to make sure you don't place that implant too far facially, otherwise you're going to end up with those situations. And in terms of interproximal tissue recession, the most important thing you could do is to avoid doing a flap. Okay, so let's see. Here's a patient who presented. She's about to get married. Here's a tooth that you can see the periapical lesion and the second premolar. You see there's not much room to the maxillary sinus. So in terms of what we have in terms of primary stability, we have very little room. And what do you think? This is a thin or thick bone phenotype? Pretty thick, right? Very nice thick bone phenotype. So this would be a great case for immediate implant placement, except the problem with immediate implant placement, many times when you try to place the implant, it wants to go right to the apex, right? Because the drill just slides all the way to the apex, which is the wrong position, right? So I'm so glad Dr. Giorno talked about primary stability. I couldn't agree more about that. I think everyone, wants to go for this really maximum insertion torque, which is really, I think sometimes we feel better if we have a lot of torque, but it's not good for the patient biologically. So what we really need to do is to really identify the optimum location, which is we have a small patch of bone to install that implant to, but not with a lot of torque. I think everyone was trying to under-prepare and use a lot of torque, because if people think about primary stability as if the more the better, and it does have some detrimental effects. So let's see how we're going to manage this case. We start with using a piezosurgery to facilitate the extraction, and then after extraction we're going to perform our osteotomy. Minimum osteotomy. There's no reason to do the, to try to have that really high insertion torque. And I think also the position is really important. You can see that the implant osteotomy was on the palatal, the way it was pointed out on the CBCT. What I like to do, I like to coat the implant with a liquid PRF. We heard the beneficial effects of PRF on the surface and how it interacts and synergistic effect with the OSSEAN surface, so we're going to take advantage of it. Why not, right? Relatively medium insertion torque. I don't try to go for maximum. Usually for immediate loading, anything between 20 to 30, 35 maximum is what I will go for. So once the implant is in position, we're going to go ahead with the immediate provisionalization. Most patients don't like to walk around with an empty space. We'll make the immediate provisional, and then the grafting is very important. Now, I already told you that this is a thick bone phenotype. If you don't want to graft that thick bone phenotype, you don't have to. The data shows that even if you don't graft that, there's very little change. But if we can accelerate that by addition of PRF in there, and it can actually improve some of the patient experience in there, I think that's important. So we are going to place the graft material around the periphery of the implant. Then when we place the PRF, we put some of the solid matrix as a way of controlling the wound healing in that area. So you just have to make sure that you keep it out of occlusion. You just check the occlusion and keep it out of occlusion. And you see, this is where we place the implant, and you don't have to have this gigantic implant. The wider is not better, okay? Because you want to allow bigger gap between the implant and the socket. And you see, we have a lot of space in there. The more space you have, the more room you allow for bone to fill in. And I think the argument was made for the Blossom as a design. It really comes to effect for immediate implant placement. You really see the benefit of that Blossom design. And you see that this is how the patient left with some PRF at the opening. And you see within a week, the tissues look fantastic. Tissues look really great during the early wound healing. And really, the patient experience in terms of pain management is much improved when we're using PRF. So here's another case. Now, this case, you see the central incisor. What do you think? Is this a thick or thin bone phenotype? Very thin. And this patient is 80 years old. Not very happy to walk around with a missing tooth, right? So she's giving me this look that you better fix it. So this is how we start. We're going to extract this tooth, but we have to be very careful in the way that we extract it to minimize damage and trauma to that facial plate. We're going to use a special device to vertically displace the tooth in a way that doesn't damage that facial plate. So we're going to control the extraction. Once the tooth is extracted, we perform the osteotomy again, directed to the palatal patch of bone that we have to install it into the bone that we have. And you see the PRF will be used, but the Blossom really helps with the positioning and the primary stability that we need for immediate provisionalization. We allow that gap. You see, we have about between 2 to 3 millimeters of a gap horizontally between the implant and the socket. So we don't necessarily go for a huge implant. We are making the immediate provisional. And then once the immediate provisional is made, we'll go ahead and graft the socket. You see, I put a PRF because that facial bone was partially compromised. So instead of using a non-active membrane, I would just use PRF as a biological matrix and then graft the rest of that socket with a combination of a graft material that was made with a liquid PRF and a particulate graft. Whether you use an allograft or xenograft, either one will be mixed in there. So once the graft is introduced to the platform of the implant, we'll remove the driver and then place the immediate provisional and then pack more of the PRF solid matrix right at the opening to assist with wound healing of the mucosa around that. So especially you see we have an older patient, we have a very thin bone phenotype, and we're going to be testing that by immediate provisionalization and immediate placement. And in an 80-year-old, the last thing you want is failure or delayed healing. So we can take advantage of all of these to try to improve our wound healing. You see the implant is not gigantic, it doesn't have to be super long, and it doesn't have to be super wide. We want to actually grow more bone rather than use a bigger piece of titanium. So the provisional, the patient is very happy. And the next day, you see, she can see the tissue by the next day. Okay, when she came in, the tissue is healing much faster as a result of that. So PRF can really help with that. What about the mucosa? Should we be doing a soft tissue graft for every one of these cases? Well, this afternoon, we'll talk more about how to manage the mucosa around that, but needless to say that this socket managing the bone is one aspect, but also managing the mucosa is another aspect. And in many of these cases, what we're doing as a peri-implant phenotype modification therapy is something very effective, which means that if your patient has a thin mucosa, we need to convert them to have a thick mucosa in order to minimize some of the risk associated with recession. So this is a patient who's had recession around some of these areas. Also, you can see this is a very thin bone phenotype. When we extract the tooth, we are sure that after extraction, we need to also think about not only managing the bone, but also to manage the soft tissues. And you see, using a VISTA, vestibular incision, subperiosteal tunnel access, it's a vestibular access. It gives you a very quick access to the facial, and we can go ahead and put a graft of a connective tissue graft in there. Just adds an extra few minutes, but it gives you an insurance policy against having further recession of the areas. And the benefit of doing the vestibular access is that you don't make an incision of the papilla, which can lead to papilla loss. So you see, with this protocol, over time, the tissues remain very stable. And what is important, by giving you that grafting of the soft tissue, you can preserve the contour. I know some are really in favor of doing bone as a contour grafting. I believe that tissue is more effective in contour augmentation than bone. So what about if there's already a recession? Sometimes we want to place an immediate implant. You can see the patient already has a recession. How do we manage that? Can we do immediate implants in this situation? So here you can see very thin facial plate, very, very thin, and the patient already has a fractured tooth. So we're going to be extracting that. But you see how thin that facial plate is. And the patient already has recession on that tooth. So you see, this is what we're talking about with VISTA, vestibular incision, subperiosteal tunnel access. So when you make that tunneling on the facial, you are making access to the facial bone. I like to make the vestibular access first before extraction, because after extraction, if you try to manipulate that area, that bone is so thin, you're going to fracture that. So while that extraction is taking place, I'll show you the osteotomy. Osteotomy directed on the palatal aspect. You have to be very precise with the positioning of the osteotomy. You could do guided surgery if you like. But I want you to see how thin that facial plate is. You can see after the tooth extraction, look at how thin that facial plate is. When I put my perio probe in there, you can see the shadow of the probe through that. So this is what you call a thin bone phenotype. So the way to manage a thin bone phenotype is to allow a bigger gap between the implant and the socket, and make sure to graft it. So you see we have about 3 to 4 millimeters of a gap between the implant and the socket. So you see the implant is placed. I use PRF, coating the implant surface, putting the graft material, and you see I'm harvesting a piece of connective tissue graft from the tuberosity, and having that access right in the vestibular access gives you the ability to graft the tissues around that, to manage that recession simultaneously. So you see I just sutured a very small piece of connective tissue graft in that area, and you see immediate provisionalization and putting PRF within the vestibular area to allow the faster healing of the tissues and bone. So you see, we're basically correcting that recession with this immediate placement, provisionalization, and connective tissue grafting to manage it simultaneously. So just a conclusion, important aspect is risk assessment. Don't just begin the treatment and treat everyone the same. By risk assessment, you define the patient's phenotype. Does the patient have a thin or thick bone phenotype? The thin bone phenotypes are the ones that you have to be extra cautious about. Those are the ones that require graft in the socket for sure. Okay, you cannot just allow those extraction sockets to resorb on their own. But also, the mucosal phenotype, defining it is very important. This afternoon, I'll talk more about the management of the soft tissues around the implants. And then the protocol is really important. So we know that socket grafting can reduce the dimensional loss that is going to come with tooth extraction. LPRF is very important biologically as well as clinically. It can help to reduce some of the dimensional loss if we mix it with some less resorbing kind of a particulate graft material. You can actually take advantage of the more volumetric stability, but also the LPRF improves the patient experience, reduces the pain, reduces swelling, edema, and it's accelerate the wound healing of the tissues and the bone. And we also manage this with socket graft, with soft tissue grafting to modify the patient's phenotype from a thin tissue to a thick tissue. And the implant position is extremely important. You have to make sure that if you're planning on immediate implant placement, it's really hard to control the position of the implant, but you have to direct it to allow more space between the implant and the socket. So with that, I would like to thank you for your attention, and I look forward to a discussion at the end with my colleagues on the panel.
Thank you, Dr. Ziad, for this excellent presentation. Yes, as mentioned, we will leave the Q&A session to the end of this session. Our next speaker is Dr. Farzin Sarkarat. He received his DMD and specialty in oral and maxillofacial surgery and implantology from the Medical University of Tehran. He is the head of the oral and maxillofacial surgery department and the Craniomaxillofacial Research Center at IAU in Iran. He has a fellowship and diploma degree from the IAU of Dr. Sarkarat Maxillofacial and Cosmetic Center in Tehran and then Sofaces Cosmetic Clinic. He has published and authored one book and other chapters and other books. So, kindly welcome Dr. Sarkarat.
Thank you very much, Dr. Ziad, for your nice introduction. First of all, I would like to express my sincere appreciation to the total core team for organizing this special event, and also especially my dear friend Ashkan to give me this opportunity to be here. Today, I just wanted to speak about a special topic. It's the alveolar bone reconstruction using the thigh mesh and LPRF. Sorry. As an introduction, first of all, I just wanted to emphasize to some points about the phenomenon of the bone resorption and different treatment solution of it. Dr. Homa talked very nicely about the pattern of the bone resorption after the extraction. We have 5 main topics that we can divide the bone resorption. One is the after extraction, and you know that the main thing after extraction is due to decreased blood supply, disuse, atrophy, and unfavorable prosthetic pressure. This is very important to emphasize that the labial aspect of alveolar crest is principal site of resorption, and in the maxilla, residual alveolar ridge is going upward and inward, and in the mandible, it is the downward and outward. The second reason for bone resorption is the trauma. The important point is that mostly in these cases we have both the soft tissue and hard tissue lost together. The other reason, the pathologic lesion, as you see here, this case was a 24 years old guy with the history of the cementoblastoma, and after complete inoculation and extraction of involved teeth, we have now the bone resorption here, and for doing the implant or other reconstruction is need to gain again the bone. The other reason is the metabolic conditions. You see here the OPG of a 60 years old patient with osteoporosis, and you have to note the area of the low bone density, alveolar bone loss, and tooth loss. And the last but not the least is the oral infection. Osteomyelitis that causes from the oral infection mainly happens after the infection of the bone over there, and when it happens, it can lead to the eventual death of the bone and also the soft tissue. And in this slide, you can see the panoramic view of a patient immediate after full mouth extraction in your left side, and the same X-ray in another patient in your right side with the history of extraction almost 10 years after wearing a removable denture. And we can see that how is the severity on bone resorption. Here it's shown the direction of the bone resorption and residual alveolar ridge, which is, as I told before, upward and inward in the maxilla and downward and outward in the mandible. Okay, let's take a look at different solutions. The first solution is the prevention. And we can actively intervene at least in time of the extraction phase. For some patients, we are going to do the prosthetic reconstruction, and finally the main solution is the surgical reconstruction of the missing bone. In the prevention phase, socket preservation on extraction time is one of the ways that we can make the quality and quantity of the bone for further implantation. And as Dr. Homa said, 2 days we are going to use the LPRF in combination of all graft materials that we are using for this purpose. The fresh socket implantation, thanks to you, you talked a lot about this one. There's no need for me to talk more. The fresh socket implantation is another way. It's important in the anterior part of the maxilla, in the aesthetic zone, and you can see here the single tooth replacement with OSSEAN taper intra-lock implant. And we should not overlook the role of systematic overgrafting of the buccal plate at the extraction time, because I emphasized before that labial aspect of alveolar crest is a principal site of the resorption. The prosthetic reconstruction is another way, and because of the disadvantage of the aesthetic outcome, it is just only limited to the cases in which the surgical ways are not possible due to the patient's systematic conditions or lack of operator knowledge or experience, and also for some financial matters. But the main the main way is the surgical reconstruction, and we have a wide range of surgical procedures which can apply for reconstruction of alveolar ridge deficiency. GBR with resolvable or non-resolvable membrane, intra-oral block grafting, extra-oral block grafting, and distraction, osteogenesis, which I show some of them in the next couple of slides. Here you can see the mandibular bone augmentation using the ramus block graft. In another patient in the middle is the maxillary ridge augmentation with iliac crest, ridge splitting technique, sinus augmentation with lateral wall approach, and alveolar distraction. And the last one is the three-dimensional crest bone augmentation using the bone rings. Explanation of this, detail of this technique is not part of my discussion today. I just wanted to draw your attention to some of these techniques. We can divide the defects, the bony defects, based on their morphology into two main groups: intra-bony defects and extra-bony defects. It is important to know that the defect morphology plays an important role in the success of alveolar ridge augmentation techniques. And it's very clear that it's easier to maintain the space, stabilize the augmented size, achieve primary soft tissue closure, and protect grafting site in intra-bony defects than extra-bony defects. And as you see here in this slide, there is a socket extraction defect and also the defect in the sinus under the Schneider membrane. Both of them, they are intra-bony defects, and in bottom two pictures you can see the extra-bony defects in the site of old extraction tooth and also in the trauma case. Based on the type of the defects, we have the horizontal defects, vertical defects, and mixed defects. Here you can see the horizontal defect in the maxilla and the mandible, vertical defect in the anterior part of the maxilla, and a mixed defect due to the pathologic condition of the mandible. Let me make a few important points. The amount of the augmentation may influence the risk assessment of the operation. Complications are more likely if a large amount of height or width is needed outside the natural bone after bone regeneration. And maintenance of space at the augmented size is one of the fundamental principles for surgical reconstruction techniques of the missing bone, and this one is the most important use of the tie mesh that we will see later. Of course, we have different ways to do this: the bone substitute, membranes, tenting screws, titanium mesh, and bone plates all are suggested for the maintenance of the space. And a very vital point that when significant bone augmentation is required in a severely resorbed alveolar ridge, creating the space is more critical for gain the success. Based on the above mentioned points, we can say that in the mild to moderate horizontal defects, the ridge expansion or GBR with or without simultaneous implant placement works well, but in the severe forms, using the tie mesh is a very good solution. And as well as the horizontal defects, also in the vertical defects, we can say that the tie mesh technique can work in the severe form of them, while in the mild to moderate form of vertical defect, the GBR with or without use of tent screws is predictable. Let's see what article says about the using the tie mesh in the alveolar reconstruction. Jovanovic first reported the use of tie mesh barrier membrane in 1995. He reported 4 cases. In 1996, Von Ox published an article in International Journal of Oral and Maxillofacial Implant entitled "The Time Technique." It was the new method for localized alveolar ridge augmentation prior to placement of dental implants. In his article, the time technique using the autogenous bone grafting combined with stabilization using a tie mesh for localized alveolar ridge augmentations was evaluated in 20 patients who had insufficient bone volume for the primary placement of dental implant, and he found that the stabilizing titanium mesh was best suited for vertical ridge augmentation, and another feature of the mesh was the excellent tissue compatibility with little clinical or histological inflammation, even when the mesh had become exposed. In 2008, Francisco Pieri published an article in Journal of Periodontology, alveolar ridge augmentation with titanium mesh and a combination of autogenous bone and inorganic bovine bone, a 2-year prospective study. In his study, 16 partially dentulous patients requiring bone augmentation were treated for 19 reconstructive procedures and delay implant placement, 44 implant placed, and after 8 to 9 months of submerged healing, he evaluated. The clinical examination were performed on the radiographs of the implants taken 6 months after the prosthetic loading and once a year during a 2 years follow-up. And the result was very interesting. You know, the mean vertical augmentation of 3.71 millimeter and mean horizontal augmentation of 4.16 millimeters. All of the implants were retained after 2 years, yielding a 100% survival rate. We have another good publication in 2008. It's done by Patrick Lewis, reconstruction of maxilla of mandible with particulate bone graft and tie mesh for implant placement. He published the result of tie mesh technique in 45 sites in 44 patients, 29 in the maxilla and 16 in the mandible. The success rate was 97.7% and mean height augmentation was 13.7 millimeters. It seems very fantastic. And we have too much more publications, systematic review that because of the constriction of time, I'm not going to explain all of them. And when you go ahead in time, you can find many other recent publications which shows the success and predictability of tie mesh technique. By studying all of these articles and based on available evidence, the advantage and disadvantage are as follows. The advantage is excellent tissue compatibility, space maintenance, malleability and adaptability, optimal mechanical stability, easy and durable shaping, maximum biocompatibility, and effective fixation of graft material. But like any other surgical technique, it has its own disadvantage. Risk of the mucosal perforation and exposure and placement of intermediate denture is risky and is a little bit technique sensitive. Especially it needs for critical soft tissue management. In light of all these experience and articles, I just wanted to review some important tips in this method and show you some cases. The morphology of the defect influences our choice technique. The larger the defect, the more space maintenance you need. Tie mesh is not a barrier membrane, it's a ridge scaffold supporting the soft tissue flap and it protects the graft material. I mean that by tie mesh technique, we are doing the protected bone regeneration technique. It means that we're using a rigid scaffold to support the soft tissue flap and it protects the graft. In other hand, by GBR or guided bone regeneration, we are using a cellular occlusive barrier membrane to prevent the ingrowth of connective tissue and direct growth of new bone into a site. Thigh mesh allows cells and vessels to go through. The tolerance to the exposure is very good and it's acceptable. Mesh must be thin enough to cut and shape and thick enough to support the soft tissue, maintain space and minimize micro movement. The bigger the defect, we have go to the thicker the mesh. Commonly, we are using the 0.2 millimeter mesh for alveolar bone reconstruction. As I told before, it tolerates exposure much better than non-resorbable membranes. And regarding the pore size, macro mesh shows better result compared to the micro mesh. The epithelium can grow underneath the mesh and exposed on the exposed mesh, and mesh removal can be a little bit hard in this situation. We have to pay attention to the biotype of the gum when we are considering the thigh mesh technique, because there is the increased risk in the thin biotype patients. And the technical point is that when we are using this method, we have to do it with the distance at least 1 millimeter between the mesh and neighboring teeth. Rigid fixation is mandatory. It has to be in the labial side, and sometimes we are adding some screws also in the lingual side, and we have to avoid the sharp edge of the mesh. Using of the blood extraction, that LPRF is one of them, is combined with thigh mesh, improves the soft tissue healing. This issue first published in the Torres article in 2010 in Journal of Clinical Periodontology regarding the use of PRP in the thigh mesh technique. And as you see here, we have 5 rules for success: good space maintenance, good vascularization, rigid fixation, perfect adaptation, and tension-free closure. The thigh mesh can also be remodeled on a cast before the surgery, selecting and trimming the mesh as you see here, and bending the mesh properly to achieve the maximum adaptation. We have to pay attention to the bone landmark, applying the mesh on the cast, and when we use in the mouth, we have to do the rigid fixation, and here you can see the result in re-entry surgery. This is the well-adapted, well-fixed thigh mesh with bone substitute and re-entry and putting the implant. This slide shows us the 2 monocortical screws on the buccal side and 1 in the palatal side for fixation. When we are using the thinner mesh, like the 0.1 millimeter, we can shape it mostly intraorally, but it's better to pre-shape extraorally the thicker mesh to reach the more adaptation. And nowadays, we have the 3D printed customized thigh mesh. They are widely now using based on the CT scan and cone beam CT. The companies made them and sent to use, and it reduces the time of the operation significantly. Let's see some clinical cases. A mid-aged gentleman referred to me with this appearance. It is a removable denture for duration of 14 years, and as you see here, this is the severe bone and soft tissue loss in the anterior part of the maxilla resulting from the ill-fitted denture. In the panoramic view, you can see the amount of vertical bone loss that we faced with, and in the cut of the CT scans, it is very obvious the severe vertical and horizontal bone resorption. In summary, we have severe bone and soft tissue loss. Before doing the bone graft, we have to provide the good soft tissue for the patient. For this purpose, I used the OSSEAN technique, self-inflating tissue expander, one in the buccal and one in palatal side. The OSSEAN absorbed liquid from the surrounding tissue and inflate gradually. The thus it distracts the soft tissue, and after 2-3 months you have a good amount of soft tissue to cover your bone graft. And as you see here, we have a very big defect vertically and horizontally. This amount of the bone almost could not be restored by intraoral graft. Then I decided to harvest bone from iliac crest, fix it with positional screws in the side, and I used some xenografts particle to fit the bony voids, resolvable membranes, and finally tie mesh to stabilizing and space maintaining. As you see here, this is the post-op panoramic view, and after 6 months now we have sufficient bone and soft tissue to full mouth reconstruction with endoosseous dental implants. And finally, the temporary crowns, which made by our restorative team. The other case is a young lady with trauma to the anterior teeth. We have a broken root in left central incisor, and this is the appearance of the other teeth and soft tissue. In the cone beam CT, we recognize the fracture of the alveolar bone in the right incisor and also the root fracture. And after opening and extraction of broken root, we have also we extracted also the right incisor, and finally we have 2 big vertical defects. We use the tie mesh for reconstruction in combination with autogenous bone and xenograft and resolvable membrane, doing the rigid fixation and tension-free closure. And this is the post-op CT, shows that good amount of bone, both vertically and horizontally in both left and right side. And this is the panoramic view, which shows the proper level of bone comparing to the other teeth. And this is another clinical case, the skeletal class 3 patient with mini implants in anterior of the maxilla, first referred to me for doing the orthognathic surgery, mandibular prognatism, and chin elongation was the main concern. And we did the bilateral sagittal split ramus osteotomy for mandibular setback and reduction and advancement genioplasty. And this is the result after the orthognathic surgery. He was not agreeing to do the simultaneous alveolar bone grafting at the time of the jaw surgery because of the financial matters, and he went to another clinic to do that. After 1 year, he came back with the history of the failed implant treatment. As you see in the both maxilla and mandibular CBCT, there is now a severe lack of the bone in the anterior maxilla. You can see in these cuts very well, and also in the mandible. And this is the cross-section of the mandible, and we removed the failed implants and reconstruction, both the maxilla and mandible with the tie mesh technique. And after 6 months now, we inserted the implants in the maxilla and mandible, and this is the panoramic view of the implant insertion. The last thing that I want to talk about to complete the discussion is adding LPRF to this treatment package. LPRF is the abbreviation of the leukocyte and platelet rich fibrin. It's the new generation of platelet concentrates, and it's derived by a simple and rapid centrifugation of whole blood patient sample. In the absence of anticoagulant, bovine thrombin, additive, or any gellifying agents, it optimizes the wound and soft tissue healing, stimulate bone formation and maturation, and it reduces post-surgical pain and discomfort. LPRF contains fibrin matrix as native scaffold. It contains the platelet that immobilize on fibrin matrix, platelet cytokines, the role is the inflammation control, and many growth factors like the PDGF, VEGF, FGF, BMPs, and also the cell, the leukocytes. And also we can use it as a membrane, resorbable membrane in the side. It has various applications, the pain reduction for the knees, regenerative aesthetic biostimulation as a microneedle technique, and also now it's used for facial rejuvenation. It is a native scaffold, contains ECM and fibrin clot with anti-inflammatory property, anti-osteoclastogenesis property, antimicrobial property, and also it contains regenerative compounds. With these properties, it seems that very helpful in alveolar bone and soft tissue regeneration. Then let's take a look to the literature to find that it has any scientific background in this regard. You can find many articles indicate the use of LPRF in periodontal and oral and maxillofacial surgery, but due to the time, I do not want to go into details of this, just show some of these articles. And based on all of these articles and the experiences, we can see that we can say that the application of LPRF in the literature are in the treatment of periodontal intrabony defects, in the treatment of periodontal forcation defects, treatment of gingival recessions, sinus floor augmentations, alveolar ridge preservation, and for bone graft stimulation, and finally for improvement of soft tissue healing. Let's see a case. It's a young lady with history of 2 times failed implant in anterior part of the maxilla. And as you see here, this is the clinical view, the damaged soft tissue, and in X-ray, you can find the bone loss. You can see the severity of the bone loss in the different CBCT images, and we use the tie mesh technique combined with LPRF. I mix the xenograft always with the liquid LPRF, and I'm using the combination of the xenograft and autogenous bone graft, 50% of each. Rigid fixation of the tie mesh at the site, and covering by LPRF and tension-free closure. Why LPRF and combination of autogenous bone graft with the xenograft? I'm usually using the Bone Plus. Bone Plus is a almost new xenograft. It's made by Novatep company in Iran, and hopefully soon it will be made here in the UAE also. The Bone Plus has high surface area. If you take a look to this, you can find that it is almost the surface area is almost equal to the BIOS, and also it is near to the Naibek from the South Korea, and it's almost 10 times of the Cerabone and 20 times of the Encore allograft. Also, it has the high roughness and high hydrophilicity. All of them leads to better interaction with the LPRF. This is the reason that I'm choosing this type of the xenograft in combination with autogenous bone graft. And you can see the result now here in the axial section of the maxilla, and also in the sagittal sections. You can see the amount of bone that we gained. This is the re-entry operation and placement of the implant in the site. Thank you very much for your kind attention.
Thank you, Dr. So we'll move forward with our last speaker for this morning session. and then we'll have 10 minutes of Q&A before moving to the lunch break. So our next speaker is Dr. Achille Peivandi. He obtained his DDS from Garancière from the University of Paris 7, and his postgrad specialty in implantology and periodontology from Lyon 1 Claude Bernard University in France. He is an implantologist and periodontologist. He is the head of the oral surgery unit and the maxillofacial department at Lyon University. So kindly welcome Dr. Rashed.
Thank you. Well, good morning, everyone. End of the morning. As usual, I'm either the one who finishes the morning or the one who finishes the day. So today is the morning. I know we are a little short of time, so I will go. I'll just put this on if I can. Can I have the mouth key, which is, yeah. Okay. The topic that was chosen today is the management of full arch implant restorations. Because, well, as you all know, we do a lot of full arch restorations these days with fixed prosthetics. We do a lot of immediate loading, a lot of all-on-4 techniques, whatever goes all-on-6, all-on-8, whatever goes with that. But it's just today, it's a very clinical presentation to share with you our point of view and our philosophy of work when we are faced with patients who come and they need full arch implant restoration. So, in your offices every day, you have patients who need full arch restoration. So you get two types of patients who come in through the door. Either you have patients who come in and they are already without teeth, so they are usually wearing a denture, or you have patients coming into your office, they already have their teeth, but unfortunately these teeth are hopeless. They have to be pulled out and replaced eventually by implants. So we have these two types of patients coming in, and in function of each group we have different categories, and the aim of this lecture is just to show you our point of view and our philosophy of work. How do we categorize these patients and how do we go through with the treatment plans? So how do you, all right, I'm just going to go like this. Okay, so either you have patients who come in with dentures, all right, so the extractions have already done. Unfortunately, the bone resorption is in place, or you have patients who have remaining teeth which are hopeless and have to be extracted. There are two different types of patients. They're very different philosophy of work, very different communication type. So, patients without teeth, you have three groups. Either you have patients that have enough bone still to place implants. You have patients who have bone, but they need, you can place implants, but you need to reconstruct at the same time. Or you have patients who come in without any bone at all. You have a vertical loss and you have a horizontal loss, and you do not have any available bone to place implants. So these are patients without teeth coming in. So if they don't have teeth and they have, normally they, okay. Thank you, doctor. Yeah, because this doesn't work. All right, cool. All right. You should keep in mind that in our experience and what we see is all these patients who don't have teeth, they have lost tissue. And most of this tissue, you have to replace it prosthetically. So most of these patients are treated by implants and then a prosthetic that looks almost like a denture. So you have the white and you have the pink, and the prosthesis is normally screw retained. And for these patients, the treatment of choice is conventional implantology. You don't have to do immediate loading for these patients. They already have a denture. They're wearing a denture for 10, 5, 15 years, and they can wait 2 or 3 more months before being equipped by a fixed prosthesis. There's no need in going and putting them through costly immediate loading treatments if it is not necessary for them. Okay, so keep in mind that if they don't have teeth and they don't have denture, they have a denture, they can keep their denture during the healing time, and you can go straight into the final prosthesis and do whatever final prosthetics you have decided to do. But in all these cases, bone, not sufficient bone, zero bone, you have bone loss, you have a loss of DV and the lip support, and this is mainly constructed by the prosthesis. As you can see, the type of the prosthesis is not important. That could be ceramic, that could be acrylic, that could be Xantax, whatever. It's for you to decide. If you have patients with teeth, but insufficient bone, so as you said, we put in the implants, no construction is needed, and the implants are placed the same day when you do your surgery. So very conventional, you can put in 4 implants, 5, 6, 10. It's for you to decide the number of implants you're going to place regarding the patient's situation. And this is mainly the all-on-4 techniques that we do. We put in 4 implants. You can put more implants if you want. We do a lot of all-on-4 techniques because it works well and financially is very acceptable for the patients. And the results that you get are always good because you are doing a denture, and doing a fixed screw-retained denture has always good results. It's almost impossible to go wrong if you respect the protocol. If you have patients that don't have teeth, but they have insufficient bone, they have bone, but it's not that much bone, and they don't want to go through heavy surgery to reconstruct the bone, which is the case of most of the patients. Maybe 5% of them will go through heavy surgery, that's another point. But 95% of the patients, they don't want heavy surgery. They don't have the condition for it, they don't have the finance for it, they don't have the time for it. So these kinds of patients, we can place the implants and we reconstruct at the same time. As you can see on the video, this is not very. We have a lot of bone here. It's not a case with a lot of insufficient bone. We place the implants, whatever number of implants you've decided to put in. If we have dehiscence or we have lack of bone in places, we are just going to graft. As you can see, we have the 2 implants in front, which are exposed on the buccal side, because we try to put them as palatal as possible, and then we are just going to, I'm going to go a little faster because there's no point, everything has been said since this morning. We are going to use native bone, cover it up. The first contact of the implants is with the native bone, and then we'll add the biomaterial on top of it, and then we put PRF membrane or maybe a resorbable membrane on top of that. And we are going to load the implants because the primary stability in this case was good, and the patient was demanding a fixed prosthesis at the same time. Otherwise, we would have just asked her to wear her denture. That was not a problem. So we graft, we put on the PRF, biomaterials, PRF, and then we close, tension-free, we take the impression, we do the prosthesis. It's a screw-retained acrylic with a framework prosthesis that goes in. It's maybe not perfect aesthetically, but you know, and look at the soft tissue healing 2 days after the surgery. Normally we deliver the prosthesis when we do immediate loading between 24 hours to 72 hours after the surgery. And as you can see, even it was a big surgery, the soft tissue healing is good. If you don't do trauma on the periosteum and then you use PRF membranes, normally you have a very good soft tissue healing, and the pain reduction is really good, as Dr. Homa and Dr. Sarkarat said before me. Then you have cases where we have bone, but we don't have sufficient bone. Like in this case, which is almost a full arch, as you can see. It's not exactly a full arch, but it's almost a full arch. And I'm just going to go faster. No, I'm sorry, I have to go back. Yeah. As you can see here, we don't have a lot of bone. As you can see, the ridge is quite thin. But we don't care. We are going to do a screw-retained full arch prosthesis. So what we are going to do is we are going to displace our implants slightly to the palatal side. So we take the implants in. Even if the apex of the implant comes out on the buccal side, we are just going to graft over it. Okay? The position of the implant, if the head of the implant is too palatal as it should be, it's not a problem with the screw-retained prosthesis. All right, so as you can see on your right-hand side, the implants are completely on the palatal side of the wall, and we are just going to ignore the fact that the ridge is thin. And the apex of the implants is going to come out on the buccal side, we're going to graft. We have a good primary stability, and it allows us to place the implants and prevent the patient going through heavy reconstructive surgery. We are going to put the multi-unit abutments, we are going to graft, as you was shown before, native bone, biomaterials, PRF. It's almost the same protocol. We suture, we take the impressions, and then this is like 48 hours after the surgery, and then we go and we put in the fixed prosthesis in, and that's it, just retain fixed prosthesis. And that's how it goes, even if the ridge was thin. Other cases, if you do not want to do immediate loading, because it's not the demand of the patient, then you can just do the same thing. Place your implants, reconstruct, and wait for it to heal before coming back in and doing your prosthesis. As you can see, the ridge is thin, very thin, but we are going to go full arch, so we don't care. We go, you put our implants in. I'm going to show you where it's really thin, and you just pull them. We put them slightly more palatal than the normal corridor of prosthetic position, and we have the apex that comes out on the buccal side, that's for sure, and then this part of the implant we are going to graft. I'm sorry, we don't have a lot of time, so because everyone's sleeping this morning, so we started late. So as you can see, even if the implant is exposed on the buccal side, that's not a problem, and we are going. It's much easier to graft around a few exposed threads than to reconstruct a full crest by pre-implant surgery, which is sometimes more demanding. And then in this case, we close everything up we put biomaterials, and then we put the membranes. We normally suture the membranes first, and then put the biomaterials before closing, because when you put the biomaterials and then you start to put your membranes, it's the other way around. The biomaterial goes all over the place. It's not nice. Just fix your membranes, put your biomaterials, and then fold them, tag them, whatever, and then it's done. So we graft, here we used membranes. I didn't have PRF membranes in this case, I don't know why. We took 2 screws. These are Dr. Homa Zadeh screws, was designed by him. Not doing publicity for him, but I use a lot of his screws. They're very, very aggressive screws and very, very holding. I like his screws. So each membrane is just held by 1 screw on the buccal side and sutured to the palatal side. I don't tag or screw on the palatal side. It takes time, and it's not always necessary. Just suture with the mattress, suture on the lingual side, the palatal side, and then with one single screw or two screws you can fix your membrane depending on the size of the membrane. And then you close the whole thing up and you wait. So that was the second case. So if we have little bone, okay, when I'm saying we don't have enough bone, normally the resorption is lateral. We have vertical heights because the volume of the bone loss is very dependent of the volume of the roots which occupy the maxilla or the mandible. So in the interior zone, normally we have the height, but we don't have the thickness. So that's how we do. We are going to reconstruct the thickness and put in the implants palatal. But if you don't have the vertical and you don't have the lateral, then you have no bone. And when you have no bone, then you have to reconstruct bone. It's just as simple as that. Then you send everyone to Dr. Farzin Sarkarat and he will take care of it. So either you do bone grafts, but normally in the mouth you don't have enough harvesting site, so you have to go outside the mouth. And it becomes heavy. Not all patients go through this kind of surgery. And you can reconstruct. These are the kind of reconstructions we do in our services in Lyon. But these are heavy surgeries. They are demanding. It's technically demanding. It takes time to heal. The complications go with it. The soft tissue goes all over the place. So if we can prevent that happening, I prefer. So these, when we have no bone harvested from the cranial parietal side, we do a full arch reconstruction, put in the implants, and then we reconstruct as it was a normal full arch reconstruction. As you can see, the implants are very palatal because the resorption is extremely high on the buccal side for the maxilla. You can use, if the case is not too heavy, you can use maybe synthetic blocks or reconstructions if you want, but it depends on the case. If you feel that you can get hold of the thing, you can maybe do maxi-sinus grafts with blocks on each side and then put implants on each side and just ignore the interior zone. And in this case, we used, as you can see, we're very thin. I don't have a lot of height. You can't see it here, but the height was very reduced. We'll see it on the radio, on the X-rays after. So we did a maxi-sinus graft. Here, this is the block bones that we use. Well, I'm not going to go through the maxi-sinus graft. These are the block bones that we have designed with Dr. Hassania, who's sitting just here, but these are the first blocks that we designed with him. Now we have really T-bone design. These are xenograft blocks that we block in. You can screw it in or whatever. It's just like a autogenous graft, but it's not harvested, so it's easier for the patients. You can do this under local anesthesia. We don't need general anesthesia for this. And then we just block them in. If there are other blocks to put in, we put them in, we cover the whole thing around. It's just reconstruction, nothing. And then this is the results that we get. This is just a week after the surgery. And then my screw is exposed because I took a very long screw because I didn't have any more. So the 15mm screw, it was too long, but it was the only one I had. And this is the re-entry. It's just to tell you that we can sometimes, as you can see, we have good quality and quantity of bone. Even if it's not all native bone, it's enough to hold my dental implants. So here we decided to put 8 implants using always the Intra-lock implants with the blossom design because the insertion torque is not very high and it doesn't break the crest. It's very important when you have very thin crest or when you come back into grafts, it's better to have implants that do not have a very high insertion torque because implants with very high insertion torque, they will break everything up on the buccal side. So these blossom implants go in very easily, and then here we place 8 implants. We reconstruct a little bit more again over the top. It's not the subject today. We're not talking about the techniques. And then that is the result that we get. We had done an all-on-4 for this patient a few years before, and then we reconstruct the whole thing and put in 8 implants. And then we put in the gingival formers, and the patient is referred to the dentist who was supposed to take care of the prosthesis. Or you can go zygomatic implants. That's another solution for patients who have no bone. You have to be trained for that. Maybe you need a general anesthesia or heavy sedation, but you can do zygomatic implants if you go to the Paulo Maulo clinic. I'm very friends with the team that work in Lisbon, and they do now a lot of zygomatic implants. A lot of patients with no bone are referred, and they put in zygomatic, quad-zygomatic or normal zygomatic, whatever. It's a technique, you have to learn it. It's possible, but you need the environment that goes with it. It's not something you could do in your office tomorrow morning. And as you can see, the implants are extremely palatal, but that's not an issue. So you can see these zygomatic implants are much more palatal than the implants we put palatally. So these were the patients without teeth. All right, but easy, normal implantology, you don't have to load, you wait for it to heal, and that's it. Patients have denture, they keep their denture during the healing time, you do the prosthetics one time, and that's it, we don't talk about it. But when you have patients with teeth, it's a very different story, because a lot of patients come in with teeth, and you can't just announce to them, you know what, I'm going to pull all your teeth out, and we're going to put implants, we're going to do a full arch implant, prosthetics on the implants. They just panic. Because a lot of these patients are not informed, they don't know what's happening to them, they don't know what a periodontal disease is, they're not conscious of that, it's maybe the first time they're coming to specialists. So be careful about the communication, it's important. You can't just announce to people, you won't have any teeth tomorrow morning. So, they are decisions. Either you keep the teeth and you decide later. You do some kind of solutions. We're going to keep the teeth 5 to 7 years, and then we're going to bring the patient slowly into the full arch implantation. But he will be prepared mentally and financially for it. Or you do immediate loading, because if they have teeth, they want teeth. They don't want a denture as a provisional. That is the most important thing. It's not the same thing as someone who has already a denture. Or we do strategic implantation, extractions. We are not going to pull all the teeth out. We are not sure to have good primary stability on the implants. We're not sure to be able to load them. So we'll tell the patient, you know what, we're going to keep a few teeth. We're going to do a restoration fixed on your teeth. We put in implants, and then we're going to switch. When the implants are osseointegrated, we're going to put the prosthetics on the implants, and we're going to pull out the other teeth remaining. And the last one is connecting teeth to implants. This is one solution. I'm not saying that is the best solution, but in some cases, it can be the best solution in some cases. So, keeping lost teeth and deciding later, why not? Why not? We have patients who come in with periodontal disease, teeth moving all over the place, but the patient is not ready mentally for a full arch implantation, and he doesn't have the finance for it. But you have to find a solution for him. You can't just tell him, well, I'm going to clean a little bit and then you come back. That doesn't work. He has teeth moving all over the place, he has a little pain. So what we do is we do whatever we can do. We are going to put him through some fixed prosthetics, provisional, not very costly financially, and then we're going to come back later. So these are acrylic with a little framework prosthetics with a few extractions, and then we come back in, we do some cleaning for the lower jaw, and we're going to split the teeth together, and this is the results we get 5 years later. 5 years later, or 3 or 2 or 7 years later, the patient is ready mentally and financially for a heavier treatment, so he will come in, he won't go anywhere else, he will come and see you, because he trusts you now. And this is how it was before. Well, it's the same thing on the left side, but now we can go through implant treatment. That was the periodontal problem. Sometimes it's decay problem. Decay problem is easier to handle. If the patients are not ready for it, they don't have the finances for it, sometimes you can just go normal, just very conventional dentistry. We forget that. A lot of times we're just going to pull all teeth out. That's not the only way of doing it. Sometimes you can keep these teeth for 7 years, 6 years, and then you can come back in and do implants if you need. This patient was restored by teeth, by fixed prosthetics, but I know that we're going to go back in 10 years afterwards. but she will have teeth for 10 more years. Immediate loading, we talked about it. I'm not going to go through it again. The only thing you should consider that most of these patients who need extractions have recessions. They've lost bone, and keep in mind that the position of your implants won't be the position of your teeth. So you won't have the same type of prosthesis that the normal teeth. If you have vertical bone loss, your implants are supposed to be on this line, but the implants will be on the other line. You have bone to put implants, but the implants are not at the right position. So instead of being here, the implants will be here, and then we have to do some pink porcelain or acrylic or whatever to replace the missing bone. Otherwise, you would not have the lip support and the aesthetics that the patient is demanding. You will have your teeth, but the patient won't be happy with the aesthetics. Take that into consideration. So for the immediate, you can go flapless surgery. If the conditions are good, you go flapless. It's the best way of doing it. Palatal position, overgrafting, impression, whatever. And as you can see, we do a framework, and then this is the prosthetics that would deliver 24 hours after the surgery. I put this video on for you no, I didn't put it on. It was just to show you how good is the soft tissue response is when you go flapless. This patient, another one, full arch, upper lower jaw, the same day. We put in the implants, we take the impressions, and then we deliver the prosthesis within 24 hours because we have good primary stability and we know that we can load the implants. This is the impressions. This is the patient coming in 48 hours after the surgery, and then we're just going to screw the prosthesis in. And depending on the bone loss that the patient has before or after, then on the final prosthesis, we're going to adjust ourselves. Are we going to do pink or not to do pink? It's with the triumphs that we decide which option to hold. So as you can see, the soft tissue heal is extremely good because we used PRF, we used overgrafting of the buccal bone, and we did not induce trauma to the periosteum. The most important point that we didn't talk about this morning is not to traumatize the periosteum. You have to work fast and you have to work clean. This is the issue, this is the key issue. You have to go fast and clean. And then you will have the PRF to help you out, you have the biomaterial to hold the volumes. And that's how the patients are. And this is two days after the surgery. You can see he's not, we pulled out all his teeth the same day. We put in a number of implants, and you know, he doesn't even have a lot of swelling. He's okay. Now this is the provisionals on the other side and the final restoration on this side. Flap surgery, sometimes you have to open up because there is too much granulation tissue. So we open up, we clean up, we put an implant, we overgraft, we put whatever PRF necessary, and then we do the same thing. This is the Zantac bridge that we did. Well, Dr. Thierry Giorno is going to talk to you about this afternoon, so I'm not going to go through it. Nowadays, all the full arches that we do systematically, we have got rid of the metal. We do all the frameworks with Zantac. Those Zantac acrylic fused into Zantac bridge and then screwed in just a day after the surgery, or 2 days, maximum 2 days after the surgery. And these are the implants. We have loaded the interior implants. We didn't load the posterior implants because it was not necessary, and I didn't have enough primary stability, so no need to take risks when it's not necessary. Well, this was the treatment plan that she had. This woman, they flew from Los Angeles because she was French, working in Los Angeles, $75,000 to do just one arch. That was the treatment plan for her. We did that for much cheaper and with more implants. Same thing on the lower jaw, Zantac bridge, immediate loading, very simple technique, and we have very, very good results, as you can see. The framework, the Zantac framework, you can't see it on the X-ray. as a metal framework on the top. You can see this case was done in 2 times. The upper jaw was done 10 years ago, and the lower jaw was done last year. And this is the patient just 2 days after the surgery, 1 or 2 days after the surgery. Strategic extractions, I'm going to go fast, I'm sorry, it's a very big topic, so I'm taking a lot of time. Strategic extractions is you keep a certain number of teeth, and then we put in implants. 2 techniques that we use, either you just hold the provisional prosthesis by teeth, and the implants, you just leave them alone, or otherwise you are going to connect your implants, you are going to help the implants by a certain number of remaining teeth for the immediate loading. So 2 techniques. So either we go provisional only on teeth, so we extract, as you can see, she needs extraction, all of the teeth are gone, we are not going to all extract, we're going to put 4 implants, keep the others, do a bridge on the remaining teeth. It's not a perfect bridge, as you can see, it's far from being perfect. And then when the implants are healed, we are going to provisional on the implants, and then we're going to pull out the teeth, put in the provisional on the implants, graft a little bit, try to correct some of the tissue loss that we had, and then we will find ourselves in a situation which is more favorable. And then we had added 2 more implants, the 2 more implants, and then we go to the final prosthesis. That was the same day of the delivery of the procedure. I didn't see this woman after to take more, because the soft tissue grows a little bit around the ceramics, but you know, the final result was good. Another case, as you can see, this is our everyday work. We have a lot of patients coming in. These people come in, they have problem. They have problems. They have been to a lot of offices. Everyone tells them, you know what, we're going to extract all your teeth, you're going to go wear a denture. And she says, oh, forget it, I'm going to keep my moving teeth. I prefer this than a denture. So you have to take care of these people. So the first thing we do, we are going to get rid of the emergency. So we're going to extract the 2 centrals. This takes 5 minutes. You extract the centrals, you're just going to stick them with the other teeth, you split them with the other teeth. So she goes out of the office, and now this woman she trusts us 100%, because we took care of her problem right away. And then we'll see her to discuss what we're going to do. So we are going to extract, strategic extractions. As you can see, we put in 4 implants. We do a bridge, which is a copy of what she had before, 4 implants. The bridge is held by the remaining teeth, and when the remaining teeth are healed, then we are going to switch. We are going to put the prosthesis on the implants, and we are going to extract the remaining teeth. But she will always wear a fixed prosthesis, and I did not have to load my implants because I did not have the good primary stability that is needed for immediate loading. So I took no risks. Another case, young lady, she doesn't want to wear a denture. She has bad bone. We keep a certain number of teeth, we put in implants, we do a bridge, a copy of what she had before, we do it on chair side, we do sinus grafts on each side, open maxi sinus graft, we put in implants, we pull out the teeth at the second time, and we are going to switch from provisional supported by teeth into provisional supported by the implants. And then we are going to do the final prosthesis. And the second option is to mix. During the provisional, we are going to connect the implants to the teeth. So, when I am not sure of having primary stability and the patient is demanding of a fixed prosthesis, I'm not going to pull all the teeth out right away. We are going to go too slow. We're going to pull out teeth in the front. I'm going to keep the canines, which are the best teeth normally to keep at the first place. We are going to place the implants, and depending on the stability of the implants, I will decide if I'm going to keep the canines or am I going to pull them out and do an immediate classic loading. So in this case, the primary stability was not very good. It was good, but it was not very good, so I prefer to keep the canines to hold a little bit more the prosthetics. So we are going to overgraph, as it was shown before. And we are going to load. We are going to take an impression for the prosthetics done by the lab, and I'm going to do a provisional myself for the patient. The patient never leaves the office without teeth. And this provisional is taken down 48 hours afterwards, replaced. This is 48 hours after the surgery, replaced by the provisional done in the lab. And the provisional is holding on teeth on the canines plus the implants. Another case, pull out, keep the canines, I don't have good primary stability, I'm going to load the implants, but I'm going to keep the canines to help them out. I'm going to do some kind of fixed provisional on the cover screws, on the gingival formers, and the bridge is done in the lab. As you can see, it's held by the implants and by the teeth, and then we are going to screw it in and cement it on the canines. The canines are going to help the implants hold. All right? So the occlusion, we're going to bring it onto the canines and take it off the interior teeth. And as you can see, the position of my implants are a little buckled, but you know, it's life. Sometimes we're not perfect. No one's perfect. But the prosthesis is held by both. During the and then, when it's healed, then you can get rid of the remaining teeth and then do your final prosthesis. As you can see, we are going to just fill up by composite the holes of the canines, and then when everything is good, then you take your impressions, and that's it. You come into a full arch implant restoration. And finally, 5 minutes, and I'm done, is the connection between teeth and implant. They are rules. Sometimes, I'm not saying this is the best option. Normally, you have 3 schools. They are guidelines. That doesn't mean if you connect teeth for implant, that doesn't mean you are crazy. Okay, so because I hear a lot of people say, connecting teeth to implant, you shouldn't. It's not the same mobility. It's not the same. We all know that. All right, it's not a big deal. So we have guidelines to respect. If you want to do it, you have to respect the guidelines. Either you have, you do a fixed connection between a rigid connection to implants and teeth. Either you disconnect the implants from the teeth with some kind of mechanism, or you are not going to connect at all. These are 3 schools. All schools are okay with me. We prefer, if we connect, we prefer to connect rigid. But normally, the guidelines are here. Choose healthy teeth, all right? Don't take teeth which are at the end of their lifespan. Do a rigid connection between teeth and implants, if you do it. Prepare very retentive preparation. And try to be very parallel between the teeth and the implants. And cement permanently when you cement. And do short ridge spans, not very long ridge spans are not very good. And you know, some patients are to avoid. These kinds of patients, well, it's not the best solution, maybe, the connecting teeth to implants. And patients with uncontrolled caries, it's not good. And in the aesthetic zone, sometimes keeping teeth is good. Okay, these are very basic rules, I know, but sometimes, like in this case, this woman, she didn't want extraction of all her teeth, so just added 3 implants, and we connected the whole thing together. We reconstructed her teeth as best as we could, and we told her that that's going to hold for, you know, 7-10 years, and then we'll go to something else. And this is the bridge. It's far from being perfect, but in her case, that was the right solution, because that was the demand of the patient. Or in this case, she didn't want all her teeth extracted. We kept the canines. We did we did a provisional on the canines, and then we kept them. Finally, I don't know for what reason, but we decided to keep a few teeth. So we went to a full arch connected implant to teeth restoration. Maybe it's not the best solution, but it is a solution. Normally, these solutions will do 10 years. If you look at the literature, connection teeth implants, up to 10 years, we have good literature. After 10 years, we don't have a lot of good literature. The conclusion is, just take some time and try to adapt your treatment plan to the demand of your patients. All the patients don't have the same demand. You can't just do the same protocol for everyone, and different protocols need learning. So with Total Co, we have a training center here in Dubai since less than a year now, but we have had already a lot of groups of people coming to us, and we train them on different topics. So don't hesitate to contact us. We will be more than happy to help you in for whatever issue. So I'm done. I talked too much. I'm very sorry. But after me it's lunch, so it's okay. Thank you very much.
Thank you, Dr. Peivandi, for this excellent presentation.
Thank you to you.
10 minutes of question and answer.
Would you please repeat your... Yes, please.
Due to problems with titanium mesh techniques, when you have soft tissue, do you suggest using titanium mesh techniques?
Yeah, the main use of the titanium mesh is for that one, the severe bone loss. Because we can make the good scaffold and space maintaining, and this is the main use of the titanium mesh.
Okay, do you yourself use this for your routine and everyday dental practice?
Not every day, but I'm using a lot because I have many referral cases because of my specialty for doing that one.
Thank you. Other question there?
Good afternoon. I have two questions for Dr. Peivandi. You showed us cases for placing the implants in a trophic maxilla by placing the implants from the palatal side. But I'm just wondering, what do you do in the lower arch? Do you still place it from the lingual side, or you place it from the palatal side?
Lower arch is not an issue. Lower arch in the front, in the interior zone, you always have bone. You just cut it down. You have a knife edge sometimes. You have a very big knife edge. So if you have enough knife edge, you just cut it down. You get rid of it, and then between the two mental holes, you put 4 implants, and then you do your all-on-4 technique. The lower arch is easy. It's easy money. It's the easiest surgery is putting 4 implants. It doesn't work, does it? The easy, really, it's...
Yeah, but it depends actually on what's the plan for your prosthetics. Because you also showed that whenever you're going to lose teeth, you're going to place the implants according to the level of the bone. So the more you cut from the bone, the more you're having the longer prosthesis in relation to
exactly. It's a compromise, my friend.
Yes, of course. So it should be a controlled compromise.
Of course. It depends on your knife. Experience shows that in the lower jaw experience, well, after a lot of clinical cases, yeah, you have like in most of the cases 5-6 millimeters of knife edge, and then you get rid of that knife edge, you get to a platform, you put in implants. I think experience shows that getting rid of this knife edge and putting the implants and adding that amount of bone into your prosthesis is much easier technique than trying to reconstruct this knife edge by any type of reconstructions that you need. Afterwards, it depends on you. It's for you to, if you think that it's better to do a tie mesh technique, as Dr. Sarkarat showed, or a block technique, it's for you to see. But I'm talking about easy, everyday cases, less demanding for the patients. You cut the bone down, and between the two foramen, you don't have to go posterior. You go between the two mental foraminas, you put in 4 implants, and then you load.
Yeah, because the issue that you already connected this to have the case with the immediate load, which is...
you don't have to immediate load, you can do conventional. Yeah.
Okay. So, other questions, not take much from the police time. I like what you said about the strategic extraction, planning to keep some teeth for holding vigilance, although it was a little bit confusing for me how can I place a temporary screw retained bridge with the cement on one of the teeth. Anyway, you showed that you're going to extract it anyway. But my question is, again, you're going to do immediate loading and you're keeping implants beside teeth that are predominantly compromised, which means that the oral environment is not the best to maintain proper clean environment for the implants to circulate. So how can you?
It's logic. If you have a tooth which has a huge infection, of course you're not going to keep it. It's just as easy as that. It's for you. When I'm telling you strategic implant extractions, you are going to choose which teeth you are going to keep. That doesn't mean you have to keep all the canines. Sometimes the canines, as you said, are infected. You have to pull them out. You can't put an implant just next door to an infected site. That is a fault. So it's for you to choose. Sometimes even the strategic implantation is not possible. That is, the teeth are so dead that you have to pull them out and you have to tell the patient, you know what, you have to wear a denture, and that's the only way it goes. I'm just telling you that in many cases, I'm not saying that all cases, in many cases, strategic implant, because most of these patients, they have teeth that are lost but not infected. So you can keep them, use them for a few weeks, all right, for 8-10 weeks, and then pull them out and eventually go on to your implants. But as I said, it's always your way of seeing the thing. It's for you to decide which technique is best. But just keep in mind that all these techniques are good. It's not just immediate loading and that's it. I only do immediate loading. I only do conventional technique. Do you know what I mean? It's for you to decide. Exactly.
Thank you.
Exactly.
We know that we do very, very big rare cases. One of the most common complications is premature resistant flap. What is your decision-making process as to when you would use a vestibular flap as opposed to a versus flap?
You mean that instead of the normal osteoporosis, we have to go to the... Yeah, it's very good option also.
What would be your decision-making process?
Actually, it depends to the amount of the bone that you want to fix in the position. You know, some of them it's not possible with doing that type of the incision because you have to reach the very good access to the top of the bone, and the only way sometimes is just doing the regular incisions and doing that. But in some cases, we can do the vestibular access, especially we wanted to do the horizontal bone grafting.
Socket sheath is another option for treatment. It is a very good biological option, but technically it's very challenging, and I've seen many problems with the socket shield. So if one wants to use the socket shield, it's available. I think it works. There's enough evidence that it works, but technically, it may lead to some more complications.
What is the question? Is the law? Yes. Well, it's life. You know, we've been doing this since 1998. You know, we've been working with this philosophy for more than 20 years. We have very, very good results. Then it depends on the patient, depends on their age. Normally these patients are already old. When they come to your office 10 years after or 15 years after, they're much older than before. They don't have the same physiology. They don't have this. You know, a lot of things happen in life. So, you know, it's a very, everyone wants everything to work forever. Nothing works forever. Even if you buy a car, you're going to take it, what, 10 years? If you keep your car for 10 years, you'll be more than happy with your car. So I think if patients have implants or any kind of treatment that we use for 10 years, I think 10 years is good. You know, it's to take. Patient, if a patient comes to us, he's 75 years old, he's a denture, we put in implants, and then he comes back at 84 or 85 and he has lost one implant, it's not a big issue. We're going to put another implant in. You know, we have a lot of, we do a lot of full arch reconstructions, and we have a lot of patients who come in with 1 or 2 failed implants because they had other problems, because they don't clean well, because they are old and they don't clean well, because they're old and they have a lot of other issues. It's not a problem. We take care of it. But what do you want to do? You can't tell everyone, you know, if you are waiting for a treatment to be forever, then you're not going to do anything.
I agree with you, but do you put these patients on a strict professional cleaning and periodontal?
Of course we do. Of course. We force them to buy the water pick. We show them how do we use it. But they say they use it, but they don't do it. The problem with the patient is, how did they lose their teeth in the first place? Do you think that because you're going to put in implants, they're going to radically change their way of seeing things? That's not true. That's not true. I have a friend, a very close friend of mine, that sometimes I go to work in some place and I sleep in his place, and I have done it all on 6, all on 4 for him like 3 years ago, and I live with him. I live with him two days a week. He never brushes it. He never brushes his teeth, and he lives with me. And I bought him a water pick, and you know, he doesn't care. He said, "Oh, we'll do it. I'll do it tomorrow. I'll do it." So you can't be with people the whole time. It's just life, you know. You have to accept it. People don't take care of their cars as they should, and that's life. You can't do anything about that.
Thank you very much. So, are we ready to move for the lunch break? Okay, so thank you very much.